Hello, my name is Abby Blumenthal. I'm a registrar in obstetrics and gynecology in Cape Town in South Africa, and I worked previously for several years in an HIV clinic, and I've used the experience working in an HIV clinic to present the up-to-date guidelines for management of HIV in pregnancy as of the end of 2018. And also pointed towards some of the new guidelines that were published in May 2019 but will be brought in towards the end of 2019 and the beginning of 2020. So I'm going to talk a bit about the effect of pregnancy on HIV and the effect of HIV on pregnancy, and then I'm going to go more into the pragmatics of mother-to-child transmission and how we can focus on preventing that, and how we test for HIV in pregnancy in South Africa, what ARV regimens we use, and then how we go about initiating treatment, including what baseline tests are needed, what counselling we give patients, and then how we follow them up in pregnancy and breastfeeding. I'm also going to talk a bit about how we manage unbooked patients in labour, and then lastly I'm going to look briefly at how we deal with needle sticks, as these are a common problem in obstetrics and gynecology anywhere, but particularly in South Africa where the HIV prevalence is high. So first of all, to talk briefly about the effect of pregnancy on HIV. So pregnancy is a condition associated with decreased cell-mediated immunity and low circulating levels of complement. So it was postulated that maybe pregnancy may have an effect on the progress of HIV in the body. However, studies have shown that this is not the case. These studies are taken from the pre-ART era, so obviously they have to be taken with a pinch of salt in terms of the relevance to the current era where women are on ARVs. But in the pre-ART era, they looked at women who were HIV positive who had pregnancies and compared them to women who were HIV positive and didn't have any pregnancies, and there didn't seem to be any difference in the rates of decrease of CD4 counts over time. Having said that, women with low CD4 counts in pregnancy have a double whammy of immune compromise of HIV and pregnancy, and they are at risk of infection. So women do die of HIV-associated infections in pregnancy. But women with higher CD4 counts, their overall health and their progression of HIV doesn't seem to be affected by pregnancy or the number of pregnancies that they have. In terms of the effect of HIV on pregnancy, the story is quite different. HIV has a significant effect on pregnancy and on the risks associated with pregnancy. So this was an audit done in Cape Town in the early ART era in South Africa, where women in the Western Cape had access to AZT in labour and in early pregnancy, and access to AZT and Nevirapine in labour, and the stages at which they were put on different medications depended on their CD4 counts, but no women were on lifelong ARVs in this stage, except those involved in certain projects supported by NGOs in some of the townships. And this audit showed that women who are HIV positive were at significantly increased risk of all the major complications associated with pregnancy, including double the risk of stillbirth rate, nearly 50% higher rate of early neonatal death, double the rate of perinatal mortality, increased risk of infection, intrauterine growth restriction, antepartum hemorrhage compared to HIV negative women, and higher risk of neonatal encephalopathy, more than double compared to HIV negative. This can also be borne out in the maternal mortality statistics. As the HIV epidemic took hold in South Africa, the maternal mortality rapidly increased from 1998 to 2009. It increased year on year, and the main area that increase was seen was in the non-pregnancy related infections, and that's largely TB. in 2002, the Treatment Action Campaign sued the South African government, saying that they must provide medication to prevent mother-to-child transmission. That started in 2003, but was effectively just one drug in labour at that point. But also they started rolling out ARVs for people with very low CD4 counts. However, it was fairly lackluster in the beginning, and the access to ARVs was poor nationally. Only 85,000 people were on ARVs by 2005. However, it started to pick up pace with the end of the Mbeki government, and by 2008, 680,000 people were on ARVs in South Africa. In 2010, the government policy changed to offer ARVs to all pregnant women. Those with low CD4 counts were offered lifelong ARVs, and those with high CD4 counts were offered ARVs for pregnancy that would then stop after pregnancy, and that obviously comes with its own health issues. So in 2012, in the Western Cape, all pregnant women were offered lifelong ARVs, and by 2015, nationally, all pregnant women were offered option B+, which is lifelong ARVs regardless of CD4 count. And now, as of 2018, the South African policy is see and treat. So all HIV positive individuals, regardless of pregnancy, regardless of CD4 count, are offered lifelong ARVs at the point when they are diagnosed. This slide breaks down in more detail the individual causes of maternal mortality in South Africa from 2011 to 2017. And you can see over that period we haven't made significant inroads in hypertension as a cause of maternal mortality. There's been some improvement in obstetric hemorrhage as a cause of maternal mortality, but there have been huge improvements in non-pregnancy related infections, and that's, as I say, largely TB, thanks to increased access to ARVs across the country for HIV positive women. So management of HIV in pregnancy is really important, both in terms of looking after the health of the mother, but also in terms of preventing HIV transmission to the baby. So in 2004 in South Africa, before exposure or availability of ARVs to pregnant mums, around 20% of babies born to HIV positive mums were testing positive by 6 weeks post-delivery. By 2015, this number has gone down to 1.8%, which is a fantastic improvement. But obviously there are still areas of care that we can tighten to try and reduce that number of HIV positive babies down even further, if possible, as close to zero as possible. And the areas that we can look at now in 2019 to continue to see that number improve is, number one, focusing on prevention of seroconversion in pregnancy. And I'll come back to that a little bit later as to why that's so important. But the areas that we look at there are, number one, encouraging condom use as much as possible during pregnancy and breastfeeding. Obviously, where patients know that they're in a serodiscordant relationship, making sure that the partner is on ARVs, and possibly thinking about usage of PrEP or pre-exposure prophylaxis for the HIV negative pregnant woman, and educating couples about the importance of at least condom use, but ideally maintaining monogamous relationships where possible in pregnancy to prevent exposure to multiple partners. For women who are known HIV positive, close viral load monitoring is really important, because maintaining a low viral load is what reduces that risk of transmission to the baby, both during pregnancy and labour and delivery, but also during breastfeeding. Adherence counselling is really important, both for all pregnant women, but also in a targeted way towards those women who've shown signs that adherence may be a problem. So, for example, where we're seeing blips in viral load that don't quite meet a level where they constitute viral failure, but they may suggest episodes of poor adherence, or women who've had a treatment interruption before pregnancy, or women who may be attending late for their dates and suggesting general issues with adherence to care. If viral failure does occur, it's really important to recognise it early, because getting it down by the time of labour and delivery is really critical, and I'll come back to that in the next slide as to why that's so important. In women who have a high viral load, if the resources allow, you can offer caesarean section delivery, as this has been shown to reduce mother-to-child transmission during labour and delivery by about 50%. Having said that, it does come with risk to the mother, because performing a laparotomy, which is obviously necessary for caesarean section, comes with significant risks in a woman who has a high viral load and may also have a low CD4. And so that the benefits of the baby need to be balanced against the risks to the mother. So why is this labour and delivery such a critical period? So this data at the top of the slide comes from the pre-ART era, where they looked at women who booked in a pregnancy, were known to be HIV positive, followed them up through 9 months of pregnancy, plus minus 24 hours of labour and delivery, and then 24 months of breastfeeding. And overall, about 40% of babies are HIV positive by the end of that 3-year period. 5% of women tend to transmit during pregnancy, 15 to 20% of women transmit during that very short period of labour and delivery, and about 20% of women transmit during breastfeeding. So you can see that 24 hours of labour and delivery accounts for half of the HIV positive babies by the end of that 3-year period. So it's a really critical period where it's so important to have the viral load down to reduce the risk of transmission. As I say, this data is from the pre-ART era with a steady high viral load, and if the viral load is suppressed, then the risks of transmission in all of these periods is hugely less than these numbers. During breastfeeding, which is the long period of 24 months, the risk is thought to be about 1 to 2% per month of breastfeeding in a woman who's not on ARVs. But as I say, much less, more or less zero in a woman who is adherent on ARVs with a suppressed viral load. So how do we do HIV testing in South Africa? So the pregnancy testing schedule says that every pregnant woman should be offered voluntary counselling and testing when she books in pregnancy, and then at weeks 20, week 32, in labour, 6 weeks postpartum, and then every 3 months during breastfeeding. And that's to try and pick up these HIV seroconversions as early as possible. In South Africa, the seroconversion rate varies depending on the studies that have been done, but plus minus 4 to 5% of women seroconvert during pregnancy. But these account for 1/4 of the HIV positive babies by the end of pregnancy and breastfeeding. And that's because I'm not going to the full detail of the physiology of HIV, but anybody who's studied HIV in medical school or whatever will know that when someone tests positive for, when someone is infected with HIV, in an early stage of infection, the CD4 count plummets and the viral load goes through a massive peak, and then those go down. The viral load then comes down, not to 0, but becomes much lower, and then gradually increases over the next 5 to 10 to 15 years of the progression of HIV. And the CD4 count as the reverse goes through plummets down low, then goes back up to a more detectable level, to a higher level, and then gradually decreases over 5 to 10 years as HIV progresses, and it progresses at different rates in different individuals, but over that time it will gradually decrease. And so that surge in viral load that occurs in the early stages of HIV, if it occurs during pregnancy or during breastfeeding, then the baby is exposed to that surge in viral load either in the mother's blood, in the placental circulation, or in vaginal fluids if it occurs around the time of labour and delivery, or in the breast milk, and significantly increases the risk of HIV transmission. If a rapid test at any of these testing opportunities is positive, the second rapid test is done, which should be a different brand, and that's all that's needed to diagnose HIV in South Africa. And ELISA is only indicated if you get a discordant result, so one result is positive, the other one is negative, or if it's hard to read, it looks like half a line, you're not sure, then it's reasonable to do an ELISA. The other situation where one might do an ELISA is if you have somebody who clinically looks to have conditions suggestive of HIV, maybe opportunistic infections that you wouldn't expect to see in an HIV negative person, then it's reasonable to do an ELISA even if the rapid tests are negative, just to be absolutely sure. So what regimens do we use to treat HIV? We tend to build our ARV regimens by taking one drug from the top line here of ARVs. These are all nucleoside reverse transcriptase inhibitors. The newer drugs like tenofovir have a lower side effect profile than the older drugs like AZT or even older stavudine. And then also there's other options that we have available now, like abacavir, which is used for patients who have chronic kidney disease. Then we tend to choose one drug from this middle row, which is lamivudine or emtricitabine, and both of those have this letter C in their abbreviations. The C we use to remember that they cripple viral fitness, so they impair the virus's ability to replicate even when patients have a virus that is resistant to these drugs. So they're useful both in first line and second line regimens. Even when a patient has a virus that's resistant, they still have an effect in improving the efficacy of the other ARVs that the patient is taking. And then we choose one drug from the bottom row. And the first line regimens are NNRTIs are the third drug that's used. Now mostly efavirenz because of its lower side effect profile, but in the older first line regimen, some patients you'll still see are on nevirapine. And then second line regimens tend to use these more potent drugs which have higher resistance thresholds. Aluvia, which is lopinavir and ritonavir, or atazanavir and ritonavir is sometimes used. And then we're going to come back later to dolutegravir, which is the new drug which is going to form part of the South African first line and also may form part of second line regimens for many of our patients. So how do all these drugs work? So they all target different stages of the HIV life cycle. So HIV needs to find the CD4 cells because that's what it uses as its replication tool. So it needs to find the CD4 cells by binding to the CD4 cell receptor. And so some newer drugs are targeting the binding of HIV to the CD4 cells, new drugs like maraviroc. Then the HIV needs to fuse with the cell membrane to allow its proteins to enter the cell. And other newer drugs are targeting this process of fusion. So fusion inhibitors like enfavirenz. These are not part of the standard South African regimen at the moment. Most of the drugs that we use are nucleoside reverse transcriptase inhibitors. So they mimic the nucleosides that make up the DNA that the HIV RNA needs to be converted into, and they block that process of converting the HIV RNA into DNA. So nucleoside reverse transcriptase inhibitors include tenofovir, abacavir, lamivudine, emtricitabine, and then the non-nucleoside reverse transcriptase inhibitors. So they're not mimicking those components, include efavirenz and nevirapine. So they're all targeting this process. Then we have drugs that target the integration of the HIV DNA into the CD4 cell's own DNA. Those target this process called integration, so integrase inhibitors, and that includes dolutegravir as well as raltegravir. And then lastly, we have protease inhibitors, so they prevent the breakdown of the complex viral proteins into individual proteins that can then function within the virion. So the current fixed drug regimen that we have available in South Africa contains tenofovir, emtricitabine, and efavirenz, and it comes in a number of different brands depending on which area of the country you're in and which company that particular section of government has a tender with. And it can be confusing to use the brand names because some staff members may not be familiar with the different brand names. So it's better to avoid using brand names like Oddimune, Tribus, Atripla, Atroiza. They all refer to the same drugs. And rather, when writing prescriptions, to write down the individual drug components. And that's going to become particularly important as new fixed drug combinations come into the market, and we need to be clear about which medication a patient is taking. So when we prescribe, we should be prescribing tenofovir 300, emtricitabine 200, efavirenz 600 on the prescription, so that it's clear what medication a patient is taking. So how do we go through the process of initiating a patient on ARVs? So I'm talking a little bit here about the current guidelines as I say, the end of 2018. But I'm also going to make some reference to the new guidelines which were published in May 2019 but haven't yet been actioned in the Western Cape and nationally, so that people have some idea of what's coming when the new guidelines are released. So what are the baseline tests that we do if someone has a rapid test now in pregnancy which is positive? So all women need to have a CD4 count done, and they need to have a creatinine done. There's no other baseline blood tests that need to be done unless there's issues with some of those blood tests. Hemoglobin is only necessary if the patient is going to be starting on AZT. Obviously, it is part of the routine booking bloods for any pregnant women, but it's not necessary as part of the HIV workup. If the CD4 count comes back as less than 100, the patient needs to have a CLAT or a CRAG, cryptococcal antigen test, and in the Western Cape that's done automatically. But obviously you need to make sure that if you see the CD4 count is less than 100, you need to look through the results and make sure you check the result of that test. In the current guidelines, pregnant women should be offered a pap smear in the early stages of pregnancy. The new guidelines are going to say not to do a pap smear in pregnancy because there's an increased risk of false negative or false positive results due to inflammatory changes associated with pregnancy. The other possible options include doing a pap smear, but counseling the women that they should have it repeated a year later, as it may be negative, it may be a false negative result. But it seems to be an opportunity where women engage with care, where they may accept a pap smear when it may not be done in a busy ARV clinic at a later stage, but that's something that can be discussed with patients on an individual basis. All pregnant and breastfeeding women should be initiated on ARVs the day that they present and test positive, unless there's a significant contraindication to doing so. The most important of these is if the patient has active symptoms of TB, and if that's the case, then we need to exclude TB before we start ARVs, because if they have TB, starting them on ARVs before they start on TB treatment is likely to cause a iris reaction. Inflammatory immune reconstitution inflammatory syndrome. Other contraindications include known renal impairment, in which case you'd want to avoid starting the patient on tenofovir, but it would be reasonable to start them on an abacavir containing regimen and then get the results back. If they have active psychiatric illness, then they shouldn't be offered efavirenz, but there are other regimens that can be started on presentation, and with the new regimens that are coming out, we can talk about that shortly. That doesn't include depression, and it doesn't include previous history of psychiatric illness, although obviously patients who have previous history of psychiatric illness do need to be monitored closely to make sure they're not developing side effects on the efavirenz. If efavirenz or tenofovir are contraindicated, the guidelines say to start AZT alone twice daily and then refer urgently to infectious diseases. I think in the current era where we have good access to other drugs, then, for example, if a patient has renal impairment that's not so severe that one needs to calculate the doses of the other drugs, it's perfectly reasonable to start abacavir, 3TC, and efavirenz, and then refer to an appropriate level of care to manage the renal disease in pregnancy, as well as an ID clinic to perhaps help manage the HIV. But the current guidelines say that this is the way to manage those patients, but I think it's perfectly reasonable to start abacavir containing regimens in patients who have a mildly elevated creatinine. Or the other patients who we don't start on the efavirenz containing regimen are those patients who were previously on a second-line ARV regimen but they've had a treatment interruption. Those patients we restart on the same regimen that they were on previously. When we initiate patients, we should counsel them about possible side effects that they may experience. Some patients can experience a rash, and most of those rashes are mild, but they should be encouraged to present immediately to the clinic if they do develop a rash, but not to stop their medication. And most rashes can be managed with antihistamines. However, it's important to pick up serious rashes that have mucosal involvement, as rarely you can get Stevens-Johnson's type reactions with efavirenz. So if there is mucosal involvement, then those patients should be stopped and assessed by someone with experience with managing side effects related to ARVs. Many patients experience bad dreams or nightmares, especially for the first month of ARVs, and most patients find it settles after that time. Tenofovir can cause renal impairment, so that's why it's important to have close monitoring of renal function in the early stages of ARVs. And rarely it can cause psychotic symptoms. So, as I say, especially those patients with history of psychiatric illness, they do need to be monitored closely and counseled to represent if they have any strange experiences. If they were previously on ARVs, or if they're known on ARVs, it's a slightly different approach. If they're currently on ARVs, they should have a viral load at booking, and if the viral load is suppressed, if they're on an old first-line regimen, they can be offered a new first-line regimen, which will involve them only taking one tablet instead of their current 2 tablets twice a day. So the old regimens is usually AZT and 3TC in a combination pill, which is their 1 tablet, and nevirapine, which is the other tablet. But there are very few women still on these old first-line regimens, and most of them have been offered fixed drug combinations before and don't want to change because they're concerned about side effects with efavirenz. And if that's the case and they're happy on their old first-line regimen, then there's no reason why they can't continue. However, if they have had a treatment interruption, then it makes more sense to start them on 1 tablet at night, which may encourage adherence with a simpler regimen. They have ongoing viral load monitoring, as with pregnant women who we initiate on ARVs. They should have viral load 3 monthly in pregnancy and then 6 monthly in breastfeeding. If they were previously on second line, as I say, you restart them on second line, and obviously those patients who have had a treatment interruption do need intensive counselling to support to make sure that they continue on ARVs during pregnancy, but also after the pregnancy. And it's important to ask the patients why they had treatment interruption. Maybe they had significant side effects on the medication. Maybe they're a shift worker, and maybe you can help them with a letter for their employer to suggest that they have fixed shifts. So if they're going to work night shifts, they always work night shifts, and then they can take their efavirenz containing regimen in the morning, and they're not continually dizzy because they're changing between night shifts and day shifts. So there are ways you can help address issues that may be causing problems with adherence. So, as I say, you start the patients on the day that they present, but that does mean you need to follow up the results of the blood tests as soon as possible. So, patients should be seen a week after initiation to get the blood results back and to assess whether there's any issues with the medication. So the first thing you obviously need to check is the result of the creatinine. If the creatinine comes back as more than 85, then patients should be changed to an abacavir containing regimen. If the creatinine is very high, then the other drugs also need dose adjustments, and that should be done in consultation with specialist ID clinics. But if the creatinine is mildly elevated, then those patients can take abacavir instead of tenofovir, and then 3 TC at standard dose, and abacavir and 3 TC come as a combination tablet called Dumiva, and they can take efavirenz, which is not metabolized by the kidney in a normal dose. So the guidelines say to switch that patient to AZT, but as I say, I think in the current era where we have easy access to abacavir without needing to write motivation letters, it's much more sensible just to change the patient to an abacavir containing regimen. It's also important to chase the CD4 count, because if the CD4 count is less than 200, those patients are at risk of opportunistic infection. So we add Bactrim, which is 2 tablets once daily, or cotrimoxazole, to reduce the risk of toxoplasmosis and pneumonia. That's to any HIV positive women, but it's really important in pregnancy, whereas we saw from the maternal mortality statistics that women are at risk of non-pregnancy related infections, and it can be a major cause of maternal mortality. So preventing those pneumonias and so on from occurring is vital. If the CD4 count is less than 100, the lab will automatically have done that cryptococcal antigen test. If the result is positive, the current guidelines say we should screen patients for symptoms of cryptococcal meningitis, and that can be anything as little as a headache. Remember, these are patients with low CD4s, so when they present with meningitis, they may not have full meningitic symptoms because they have a limited immune response to the meningitis. So if they have a headache, they need a lumbar puncture to rule out cryptococcal meningitis. The new guidelines that are coming out don't even ask us to screen for cryptococcal meningitis symptoms. They just say if the cryptococcal antigen test is positive, the patient should be referred for a lumbar puncture, and then you follow the protocol of management. If the lumbar puncture is negative or positive, either they get fluconazole or they get treatment for cryptococcal meningitis with amphotericin and then change over to fluconazole. Those patients who have a CD4 count of less than 100 should be particularly targeted to offer isoniazid preventative therapy, which I'm going to come back to a little bit later. If a woman presents in labour, either they're unbooked or they're booked, but now all their previous HIV tests were negative and now they suddenly have a positive test, then we manage that by giving them single dose Truvada and nevirapine currently, and then we give them AZT 3 hourly for the duration of labour. The new guidelines are going to say that they get the new fixed drug combination, which is tenofovir, lamivudine, and dolutegravir, and then a stat dose of nevirapine only, and they don't talk about the ongoing AZT 3 hourly in labour. They still need their baseline bloods because they're going to initiate on ARVs if they accept it with appropriate counselling. And all patients who accept ARVs should be offered initiation the following day when they're in a appropriate state to be counselled for their diagnosis and then the initiation of ARVs. And obviously those babies born to women who have been diagnosed in labour need high-risk post-exposure prophylaxis. So how do we monitor women who are on ARVs? So as I say, we do a CD4 count at baseline, and if a woman has a CD4 count that doesn't meet criteria for cotrimoxazole preventative therapy, then there's no need for any further CD4 counts. If they have a viral load done at 4 months and they're virologically suppressed, they don't need any further CD4 counts to be done. However, if their CD4 count is lower than 200, then they have CD4 counts done at 12 months after initiation and then 6 monthly until they no longer meet the criteria for ongoing prevention of opportunistic infections. So 2 CD4 counts of more than 200 means they no longer need to continue on Bactrim or whatever other prophylaxis they are on, and they can then stop doing CD4 counts. The only time you would then repeat it would be if the patient then presents either they've had a treatment interruption or they're presenting viral failure, and then obviously we need to repeat the CD4 count to see the level of immune compromise. Creatinine needs to be monitored on a patient who's on tenofovir, and the new guidelines that are coming out say month 3, month 6, and then month 12. The previous guidelines said month 1, month 4, and then month 12, and then every 12 months thereafter, to make sure that there's no sign of renal impairment, which would mean need to stop the tenofovir. If the patient is on zidovudine, AZT, then we need to do an FBC with a differential at month 3 and month 6. After that, we don't need to do ongoing monitoring of these because it's unlikely the patient will present with bone marrow suppression after this stage if they didn't have any issues by 6 months, unless it's clinically indicated. If the patient clinically is anemic or has suddenly has severe infections, then it's important to check that there's no problem here. For patients, the small number of patients who are starting on nevirapine, they do need an ALT at baseline, but thereafter only needs to be done if they develop a rash on either nevirapine or efavirenz. The other patients who do need ALT monitoring is if they're on Eluvia and TB treatment together, because that does increase the risk of hepatotoxicity. The other important thing to remember, which is true for all patients who are on Eluvia, whether they're pregnant or not, is that if you do initiate TB treatment in pregnancy on a woman who's on Eluvia, it's absolutely vital that we double the dose of Eluvia when we start the TB treatment. It's very unusual to develop a resistance to protease inhibitors, but the patients who do develop resistance to protease inhibitors are those patients who had Eluvia and TB treatment and it was forgotten to double the dose of the Eluvia. That does put the patients at significantly increased risk of protease inhibitor resistance, and that's because of the effect of rifampicin in the TB treatment on cytochrome P450. The guidelines say that patients who are on Eluvia should have fasting triglycerides and cholesterol done at month 3. However, in pregnancy, the fasting triglycerides and cholesterol are raised just because of the altered metabolism effect of the fetus on fat metabolism in the pregnancy. So I think it's probably unhelpful to monitor this during pregnancy, and actually makes much more sense to leave that to be monitored after pregnancy, because the effect on cholesterol affects the woman's lifelong risk of cardiovascular disease. It's not going to affect the risk of cardiovascular disease during the remaining 3, 6, 7 months of pregnancy, and it's better to check it when pregnancy is not skewing the picture. Hepatitis B surface antigen only needs to be done if we're going to stop a tenofovir containing regimen. Otherwise, it's not part of the routine monitoring on ARVs. Viral load monitoring in pregnancy. This is a little bit complicated, and I think the best thing to do is when you have a viral load for a patient to refer to the guidelines and go through the flow chart. This is a copy of the flow chart that is there in the guidelines. But I think the take-home message here should be that what we want to do with a patient who has a high viral load is get to a position where we can make a decision about whether or not we're going to change this patient to second-line regimen by about 35 to 36 weeks of pregnancy. So the guidelines, the flow chart breaks up those women who are in early pregnancy or in later pregnancy. So it shows here how if the pregnancy is less than 28 weeks, then you repeat the viral load at different intervals compared to if the pregnancy is more than 28 weeks. But obviously, if the woman is 27 weeks pregnant and you repeat the viral load in 3 months' time, or in 3 months' time, by the time you get the result back, the patient will be 39 weeks pregnant, and that's much too late to change the second-line regimen and have a suppressed viral load by the time they go through that critical 24 hours of labour and delivery where you really want the viral load to be suppressed. So I think the important thing is to use your common sense so that you get a result at a stage where you have time to do something about it. So in other words, anytime after about 24 weeks of pregnancy, you can repeat the viral load sooner than 3 months, so maybe after 2 months or maybe after 1 month, depending on how far through the pregnancy they are, such that you can get a result by about 35 to 36 weeks and have chance to change them onto a second-line regimen that may give them an opportunity to be suppressed by the time they get to labour and delivery. And as I say, you can follow the detail in the guideline to know how to manage individual viral loads. So IPT, isoniazid preventative therapy, is one of the medications that we can use to reduce the risk of acquiring TB. The current guidelines say that we should offer it to all pregnant women, and certainly the current guidelines still say that, the new guidelines still say that all HIV positive adults and adolescents are eligible for TB preventative therapy. However, the new guidelines say that in pregnancy it should only be offered to women with a CD4 count of less than 100. As I say, this guideline is not currently in place, but it is going to be coming out towards the end of the year or the beginning of next year. And the reason for that is that the risk-benefit ratio with women with higher CD4 counts is not so clear. There are increased risk of side effects in women with higher CD4 counts, whereas those women with lower CD4 counts are at significant risk of TB, and the risk-benefit ratio is much clearer. The guidelines don't specifically say exactly when to start IPT, but logically it makes sense to start it a little bit after ARVs so that you can tell if side effects occur, that they're occurring either because of the ARVs or they're occurring because of the IPT. The duration of IPT is 12 months if tuberculin skin testing is not available. However, if you can refer the patient for tuberculin skin testing, you can provide a more tailored duration of treatment. Those who test negative get 12 months of IPT, and those who test positive get 3 years of IPT. The key thing before you start IPT is obviously you must exclude active TB. So those patients who have TB symptoms need to be tested and screened for TB and shouldn't be started on IPT. There are risks of side effects with IPT, so some patients can experience peripheral neuropathy, and rarely patients can experience more significant side effects like hepatotoxicity. Any patient who develops rashes on IPT, it should be stopped immediately, and they should have blood tests to check that there's no signs of hepatotoxicity. And if patients experience peripheral neuropathy, then the risk-benefit ratio is really not there to continue IPT. Those patients should be counselled to stop it because obviously if patients have TB and need to have INH as part of their TB regimen, you're going to increase the dose of the pyridoxine that goes along with the INH to try and reduce the side effects. But in these patients where they don't have current TB and you're just trying to reduce the risk of them acquiring TB, it doesn't make sense to continue a toxic medication. So how do we pick up viral failure? So we've talked a bit about how to manage viral failure by following the protocol, but I just want to focus a little bit on how to pick up viral failure. One thing that I think is very unhelpful when you have a patient who has a high viral load is to ask that patient, are you taking your medication? Because every single patient you ask that question to will say yes. They're very keen to seek our approval, and they don't want you to shout at them, and so they're not going to say, no, I don't take my medication. Much more helpful is to ask questions in a more open way. For example, to ask patients, do you find that you forget to take your tablets maybe once a week, or maybe twice a week, or maybe more than that? And that shows them that there are many women that forget to take tablets occasionally, and hopefully they feel able to answer that question honestly. The important thing to notice here is that the way we move forwards in patients who have viral failure is much quicker in pregnancy than in patients outside of pregnancy. Outside of pregnancy, a patient must have 2 viral loads separated by 3 months, have had intensive adherence counselling, and then eventually should be changed to second line. However, in pregnancy, we don't have that luxury of time because of wanting to get the viral load suppressed by that labour and delivery. We're going to take a much more proactive approach to changing patients to second line. So obviously, if adherence is not addressed, there's no point in switching a patient to second line, because there's no point in changing them from a single tablet to more complicated regimens with more side effects, because if they've got poor adherence to one tablet, they're going to have worse adherence to second line regimens, and you're not going to get any progress. However, if you think that the patient has addressed adherence issues and they have a high viral load, and they have a high likelihood of having resistance to first-line regimens, and remember, it's relatively short periods of partial adherence increase the likelihood of resistance to first-line regimens, then it makes sense to change them to a second-line regimen sooner rather than later, because rather than run the risk of continuing a first-line regimen and then finding that they run through the period of labour and delivery with a high viral load. If you are going to change a patient to second line, there are some blood tests that need to be done, and those include an FBC, and that's because most of the second line regimens involve AZT, which, as I said earlier, you need to monitor. You need to have a baseline FBC and ongoing monitoring of FBC. You need to do a hepatitis B surface antigen, because you're often going to take the patient off tenofovir, and if the patient is hepatitis B positive, then they have a risk of experiencing a hepatitis flare. So those patients continue tenofovir. Those patients who are hepatitis B positive continue tenofovir alongside their second line regimen. They now need a CD4 count to be done, because obviously they're in viral failure, so the virus is replicating and will be destroying their CD4 cells, so they may be much more immune compromised than you thought based on their previous CD4 counts. As I say, there's not much point in doing cholesterol and triglycerides, and it makes much more sense to do that after pregnancy. It's important to screen for opportunistic infections, because they may be much more immune compromised than previously. And the current regimens, as I say, involve protease inhibitors and AZT, but the second line is likely to include dolutegravir when the new guidelines come in for those patients who are not currently on dolutegravir. Those patients who are now on the new guidelines going to be on dolutegravir, if they are in viral failure, then they really need a PI, a protease inhibitor, because it's a much more potent drug, and it's going to be necessary for patients who have managed to develop resistance on already quite potent drug such as dolutegravir. So what is dolutegravir, and why are we talking about it so much? It forms part of the FDC regimen in many countries already, and it's soon to arrive here in South Africa. The fixed drug combination, including dolutegravir, is made up of 3 drugs: tenofovir, lamivudine, and dolutegravir. It's ideal in pregnancy because of the rapid viral load suppression. However, the reason why there has been controversy and delay about bringing dolutegravir into South Africa is that the early studies in Botswana have shown that there may be an association with increased risk of neural tube defects. The studies are suggesting that there may be an increase from about 1 in 1,000 women developing neural tube defects to about 3 in 1,000 women developing neural tube defects. Those people who have been involved in ARV prescribing for the last decade will know that this was the same fear that was voiced about efavirenz, but newer studies suggest that it's not the case with efavirenz, and so there's some thought that this may be about better monitoring for women who are part of the study, and may not be an effect of the drug, but obviously that needs to be treated with some caution. The other thing to bear in mind is that Botswana doesn't have a folate supplementation program in pregnancy, so the baseline risk of neural tube defects is going to be higher in Botswana, most likely than in countries that do have a folate supplementation program. Dolutegravir does have a lower side effect profile than efavirenz, especially for patients who are shift workers. However, it can cause some side effects, including insomnia and headaches and mild gastrointestinal side effects. There's also some evidence that it causes some degree of weight gain, average of about 4 kilos for those patients who were started on it. So the latest WHO statement says that the benefits outweigh the risks with dolutegravir, but I think it's important that patients are counselled that in the very, very early stages of pregnancy, there may be a risk of problems with the formation of the baby's spine. For most of our women in South Africa, they usually book after those very early stages of pregnancy, so it's not going to be so much of an issue for this pregnancy, but it is important to counsel women for the following pregnancies that there may be this risk and they may want to think about using a reliable family planning, but we do think that the benefits of it outweigh the risks. There are drug interactions that we need to be aware of. It doesn't work well with most anti-epileptics, including sodium valproate, but obviously sodium valproate is not ideal for pregnancy either. It is safe with levetiracetam, which is a more ideal drug to use in pregnancy. It does need dose adjustment if it's used with TB treatment, and that does increase the risk of side effects that are listed above. And it can cause increased drug levels of some other drugs, including metformin, and the suggested maximum dose of metformin whilst people are on dolutegravir is 500 milligrams twice daily. It also interacts with chelating ions, including ions and zinc ions, and so patients should be counselled to take ferrous sulfate at a different time of day to dolutegravir, and that's obviously important because all our women are on ferrous sulfate in pregnancy. So I'm going to talk briefly about neonatal post-exposure prophylaxis. Obviously, this is usually handled by the pediatric doctors for us in the South African context, but obviously it's important to be flagging to the pediatric doctors aspects of a mother's care that you're aware of that may increase the risk of transmission and put the baby in a category of needing to have 2 drug post-exposure prophylaxis as opposed to 1 drug, which is the standard regimen. Obviously we've talked about viral load a lot, that puts the baby at high risk, and those babies need 2 drug post-exposure prophylaxis. But there are also other aspects of the pregnancy and delivery which may increase the risk of transmission. At less than 12 weeks is basically along with high viral load, so you may not have a viral load available yet, but because the patient hasn't been on ART long, they're likely to have a high viral load. But other things such as chorioamnionitis, preterm labor, prolonged rupture of membranes increase the risk. Having said that, in the presence of a suppressed viral load, it's not clear whether these factors do significantly increase the risk of transmission, but they're listed there as indications for using 2 drug post-exposure prophylaxis. For abandoned babies, we do a rapid test on those babies, and that being positive obviously doesn't show that the baby's positive, but shows that the baby's carrying antibodies to HIV transmitted from the mother. So therefore it shows you that the mother was HIV positive, and those babies need 2 drug prophylaxis. So what is the 2 drug prophylaxis? If the baby is going to be formula fed, which is not many babies these days, then they should get 6 weeks of zidovudine and nevirapine syrups. If the baby's going to be breastfed, then they should get 6 weeks of zidovudine syrup, and then they should get nevirapine for at least 12 weeks until the mother has had a suppressed viral load, and then the nevirapine can stop. And that aspect, I think, is often missed in the baby clinics. So it's really important to counsel the mums that they must continue the nevirapine until they've been told their blood test is okay. Women who are assessed as being low risk for mother-to-child transmission, so in other words, they've got a suppressed viral load, they had an uneventful labour and delivery, the baby gets just nevirapine syrup alone for 6 weeks. So to go a bit more in detail into feeding, all mums should be encouraged to breastfeed for up to 24 months. And when I say exclusive breastfeeding, obviously that includes the introduction of complementary foods from 6 months of age. The South African Nutritional Support Program does provide formula to mums who are medically unable to breastfeed, or those women who are failing second or third line if they are deemed AFAS safe. So that's the questions about affordability, feasibility, acceptability to the patient and her family, and safe and sustainable access to formula milk. And obviously many of the women who are failing second and third line regimens may not be ideal women to formula feed their babies. If these are women who have had poor access to care, may have poor social circumstances, their likelihood of them having good access to clean facilities to be able to provide safe formula may not be very good. And so that's really important to carefully assess that before saying, oh, well, you can have access to formula. It's also important to make sure that the mothers are aware that the nutritional support program only offers them formula for the first 6 months. So between 6 months and a year, when the baby still needs formula and can't have normal milk, the mothers need to be able to afford to buy it for themselves, because by that point they will significantly struggle to relactate to produce breast milk for their babies. If the baby tests HIV positive at the birth PCR, then those mums should be strongly encouraged to breastfeed for as long as possible. Number one, the antibodies that are transmitted in breast milk provide a huge benefit to that baby, and number two, it reduces the risk of exposure to other infections from maybe poorly prepared formula, and reduce risk of pneumonia that's seen in all formula-fed babies across the world. So mixed feeding in women who are adherent on ARVs with a suppressed viral load is not a contraindication to breastfeeding in carefully counselled women. Obviously, we don't counsel all our pregnant women, go ahead and mix feed your babies, that's fine, because those women who are not adherent on the medication, or maybe stop medication after pregnancy, they are not good candidates to mix feed their babies. But if a woman is taking medication and she has an undetectable viral load, then effectively the virus is untransmittable. And so we often see women in the postnatal wards who say they're going to formula feed because they're planning to return to work at 6 weeks or planning to return to work at 2 months. And they should be counselled that if they continue to take their medication and their viral load remains suppressed, it's safe for them to introduce formula if it's necessary for them. Obviously, they may be able to express milk, and they should be counselled about their rights for breastfeeding, expressing milk breaks that they're entitled to in the first 6 months postpartum if they return to work. But it's not a contraindication to breastfeeding, and breastfeeding has great benefits for those babies, even if they do start to introduce some formula when they're virologically suppressed. And as I say, complementary feeding is safe and appropriate for all babies from 6 months of age. So what details do we need to have somewhere in the file in a clerk for the patient? The full detail doesn't necessarily need to be in every patient note, but it does need to be somewhere in the maternal case record, so that when you're admitting a patient, you know what medication they're on and what medication you need to prescribe for them. So we want to know obviously details about the pregnancy, but we want to know what treatment they're on, not first line or second line, because as we've seen before, that can be different drugs in different women. We need to know exactly what drugs they're on, how long they've been on medication, what previous regimens they've been on, and that becomes relevant for if you get a needle stick from a patient, for example, you may want to know what previous regimens they were on. Are they on medication to prevent opportunistic infections? What are their blood results, or what is their CD4, and what is their viral load, and what's the date of those blood tests, and what's the result of other tests such as the cryptococcal antigen tests. And if we've got those details somewhere in the folder, it's so helpful for when you're admitting a patient, you want to be able to prescribe the correct medication. So lastly, I'm just going to talk briefly about post-exposure prophylaxis. Obstetrics is a area of medicine with a high risk of needle stick injuries because we are working in dark closed spaces where we don't have good visualization of our fingers, so I think it's important to just have a little bit of knowledge about how to manage needle stick injuries and what information you may want to get from the patient. So the basic first aid is that you wash the area where the needle stick has occurred. You shouldn't be squeezing it and causing local trauma. You just want to wash the fluid off. Obviously, there are protocols to follow in terms of reporting the needle stick, and that allows you to get access to the post-exposure prophylaxis from the area manager or the night matron or day matron, depending on the time of day the incident occurs. It's really important for somebody, which may not be you if you're panicking about your needle stick, to get a detailed art history from the source patient if they're cooperative, because in patients who have a high viral load, it can be helpful to get a detailed idea of what medication the patient is currently taking and what medication they've previously taken, what ARVs they've previously been exposed to. In terms of blood tests, the patient should have a viral load, hepatitis B and hepatitis C, and they should also have an ELISA just so that there is a medical legal record of the patient's status, which becomes relevant if there's any issues about work-related compensation and so on. You, as the person who had the needle stick, should be offered HIV testing, but that's not a prerequisite for receiving PEP. Obviously, if you are HIV positive, it's not ideal to get PEP and then to stop. So if you are positive, it's better to know your status and start the appropriate treatment. But if you don't want to do an HIV test, you should still be offered post-exposure prophylaxis. All regimens should use 3 drugs. So we used to triage injuries into high risk and low risk, and say low risk injuries could get 1 drug and high risk injuries should get 3 drugs. But that's not the case anymore. Now, if the injury contains a fluid, if you had a sort of fluid that doesn't have a risk of HIV transmission, like urine or saliva that's not contaminated with blood, then you don't need post-exposure prophylaxis. But if you had a needle stick from a patient with unknown status or HIV positive, or if you had a wound that was, or a mucosal surface that had a fluid that contains blood or amniotic fluid, then you need 3-drug PEP. Regardless of whether the patient, if we think they're high risk or low risk. It's ideal to start as soon as possible, ideally within an hour, but certainly within 4 hours. And after 48 hours, there's no evidence of benefit of starting PEP at that time. The standard regimen that is used in the Western Cape is Truvada, so that's tenofovir and emtricitabine, along with atazanavir or ritonavir. That can cause an unconjugated hyperbilirubinemia, so you may turn yellow, but it's not a dangerous form of jaundice, so no blood tests need to be done in patients who are systemically well but have jaundice on atazanavir or ritonavir. It's safe in pregnancy. If, however, you are not happy being yellow, then the alternative regimen, which is recommended as the first line by the HIV Clinician Society, is to use Truvada with raltegravir. But the safety of raltegravir is not clear in pregnancy, so it's not recommended as a first line if you think you may be pregnant. If PEP is indicated, you should complete a month. And if you have problems with side effects, rather speak to somebody and try and change to a different regimen rather than just stopping it. You should use condoms with your partner for 4 months, because if you seroconvert in the same way that our patients are at high risk of transmitting to their babies, you are at high risk of transmitting to your partner during this period of seroconversion. Sweat, urine, tears, saliva, and stool are not considered infectious unless they're contaminated by blood. You should have a hepatitis B immunity checked and a booster. Hepatitis C, unfortunately, there's nothing we can do to protect against it, but the risk of transmission of hepatitis C is relatively low compared to hepatitis B, but still higher than the risk of transmission of HIV. The reason why I say it's important to get a detailed history is because although in general the levels of resistance to drugs in South Africa is relatively low, in patients who have detectable viral loads, there are significant levels of resistance to ARVs, and there have been case reports, particularly in first world countries, of healthcare workers who have seroconverted after needle stick injuries from patients who had high viral loads, especially if the drugs used for the post-exposure prophylaxis were the same as drugs that the patient had previously been exposed to. So if you have a patient, if you get a needle stick in the middle of the night from a patient who has a high viral load, get that detailed history, start the medication that's available as soon as possible, and then when you have an opportunity to discuss with an infectious diseases physician, get some advice about whether or not, given their ARV history, given the medication they're taking, given the viral load that they have, would it be sensible to choose other options? And other options that are available is, for example, if patients have a high viral load on a tenofovir-containing regimen, you can use things like D4T, so stavudine, as part of post-exposure prophylaxis. Many people think, oh God, D4T, that's got high side effects, but actually D4T had high side effects in prolonged use. When it's used for a month, it has relatively low side effects. It's not the same as AZT, which many people found had very high side effects when used as post-exposure prophylaxis, especially nausea and vomiting. But D4T is generally much better tolerated as part of a PEP regimen. And if the patient is, for example, has a high viral load on an atazanavir or tonavir containing regimen, then you'd be recommended to take a protease inhibitor regimen or integrase inhibitor regimen as part of the post-exposure prophylaxis, but bearing in mind the protease inhibitors do tend to have higher side effects. So lastly, just a few references for some helpful reading. So the current Western Cape guidelines, it's good to have access to so that you can go through those flow charts, for example, for the viral loads, or if you have a patient who has a positive cryptococcal antigen test, you go through the protocols there. There are apps that you can download for Apple phones or Android phones, which are quite helpful at giving you access to the guidelines, although I think the latest guidelines are not necessarily included in those apps. As a nice video giving a summary of the different ARVs that are used in the regimens, going into more detail about the different medications and how they work and why we choose the different choices. And then also if you do have problems getting how to manage a specific patient, or if you have a needle stick and you want to get some advice during working hours, there's the HIV healthcare workers hotline, which you can access, which is a good place to turn to get advice if you're not sure whether the post-exposure prophylaxis regimen is appropriate because you have a needle stick from a patient with a high viral load. Thank you very much for listening, and I hope this was helpful.